We are Parker Perry, Cassidy Coburn, and Samantha Walsh, and we will be using Six Sigma to address the effects of ER upcoding in order to find a solution for Blue Cross Blue Shield of Montana.
Six Sigma is a methodology used to improve business processes by utilizing statistical analysis rather than guesswork. We use the DMAIC variables, which stand for Define, Measure, Analyze, Improve, and Control. As green belts in training, we are learning this methodology and applying it to the business Blue Cross Blue Shield of Montana. During the course of the semester, we took a deep dive into the specific problem they are facing.
Defining the problem. When someone goes to the emergency room, their total bill is calculated according to two variables, provider and facility. The provider is the doctor or the medical professional who diagnoses the patient and administers their care. The facility is made up of all the supplies and resources that were required to treat the patient. The bill corresponds with the seriousness of the case. The more significant cases require a higher level of care and more resources, which costs more. The cases are billed on a 1 to 5 scale according to medical code. The first 4 digits of the code for both provider and facility is 9928, followed by the 5th digit, which represents the severity of the diagnosis, hence the 1 through 5 scale. Deviations between provider and facility codes cause upcoding, which drives up costs for patients and insurance agencies. Currently, there are no system edits or system coding in place to evaluate CPT complexity discrepancies of emergency medical services within the emergency department without operating and administrative costs borne by BCBS of Montana.
In order to better understand the system in which our problems exist, we mapped out every step of the process, from the patient arriving at the ER to post-billing protocol. Here's where we came to an understanding that the process could fail at any of these steps, and now our job was to understand how and why they could fail.
According to a study by Paul Shoemaker, his findings identified national averages for CPT codes, with them being 7% of all claims will be 99281, 23% will be 99282, 35% will be 99283, 24% will be 99284, and 11% will be 99285. Using these averages, we can determine the effects of upcoding and how often it is occurring. We can also determine the monetary value this problem has. We conducted a 1-sample t-test for all facility codes and the provider codes to see if the coding to determine how differentiating from the national averages stated in the last slide certain hospitals were. Our findings identified the mean and mean area that would qualify averages being within the realm of the national averages and therefore being what we would expect. For this presentation, we are showing you the test for the more severe codes 99284 and 99285. The test concluded that they were in fact outside of the mean realm and failed our hypothesis.
The KJ analysis is a method of developing insight into themes and relationships among issues. Usually it helps us start with intricacies of a problem and build up to find the overall themes and connect them. The KJ analysis helped us to brainstorm possible X's. We chose to follow these 3 questions and come up with any and all answers to these questions in order to explore the problem further.
The cause and effect matrix helped us to connect our possible X variables and their outputs, the Y variables. We scored each X variable based on how much it affects the output. We then added up the total scores for each X variable in order to see which variables had the greatest correlation or effect on outcomes as a whole. In this way, we were able to pare down our variables and see which are truly the most influential and would be worth further investigating.
We performed a failure mode and effects analysis. We basically went through each possible area where a failure could take place within the process and analyzed the effects of the failure, the severity of the failure, the causes of the failure, and estimated occurrence of the failure. We looked at the current controls in place to prevent the failure and the likelihood of detection after the failure has occurred. We then took those rankings and scored each failure mode according to the risk priority number, which is a culmination of each score.
We wanted to see the potential savings if the problem hospitals, which are defined by their coding being drastically different than the national averages, would be if they were closer to those averages. When we compared the actual total cost allowed to the cost of what would be allowed had they been closer to those averages, We found a potential savings of over $1 million for the facility and over $300,000 for professional. These savings are proof that looking into these hospitals where higher codes are being recorded could save insurance companies and members money. We completed a chi-square test to see if there was a relationship between upcoding and hospitals or if the upcoding was due to random variation. We found there is a relationship between upcoding and the hospital. This information means that we are able to narrow the problem down to specific hospitals. This information will help us provide strategies and confront this issue. The fact that there could be a few hospitals that are the problem rather than a larger pool will make the variables easier to control.
Our analysis helped us develop possible solutions for the ER upcoding problem. One would be to introduce an auditing program for hospitals that generally upcode more often, or for claims that have deviations in facility versus provider code. Another would be developing training to better prepare medical professionals and coders on assigning a bill to their cases. This will streamline the process and eliminate errors. Finally, the Modifier 25 is a program that is hardwired into the healthcare databases that actually allows for deviation in code between facility and provider. Eliminating this program would drive down costs related to deviations in code.
The Pew matrix allowed us to list out the most important criteria in the decision and then compare alternative solutions based on this criteria. We then ranked each alternative as better than the datum or existing process, the same as the datum, or worse than the datum. The alternative with the most better than the datum scores became our top alternative. We decided to go with our two highest ranking alternatives, which were to review all Code 4 and 5 claims and only auto-ban claims that are coded the same for both the facility and the provider. With these two gates in place, we expect to see great improvement for Blue Cross Blue Shield of Montana.
In summary, when people go to the ER, they are billed according to the care they received from a medical professional and the resources needed to provide that care, or the provider in the facility. ER upcoding is caused by variation in billing codes between the provider and the facility. When the codes don't match, it costs patients and insurance agencies money. The data indicates that ER upcoding occurs more often at certain hospitals than others, which is a red flag. The data also indicates that on average, hospitals in Montana have disproportionately more severe cases than compared to the national average. This results in higher medical expenses for both patients and agencies. Solutions that can improve the ER upcoding problem are introducing an audit, developing more training, and eliminating programming that encourages deviations that lead to upcoding.